So hello, dear President, hello, dear colleagues. Moving on with the third case, a patient with torrential TR due to carcinoid heart disease, 93-year-old female, patient BMI of 33.1, short of breath and fatigue with signs of right heart failure, ascites, anasarca, multiple hospitalizations for IV diuretics, ascites drainage, and as we said, metastatic carcinoid in the last 6 years on telotristat and somatostatin. Wide open tricuspid valve with free TR. We have also a hepatic flow reversal. From the rest of the history, chronic AF, chronic disease, anemia, and hypothyroidism. We have a high Euroscore 2 and a tri-score of 22%. We see the left ventricle non-dilated, and we see the images of torrential TR, a wide open tricuspid valve, as we said, due to carcinoid. Here are our assessments. We see an area of 15.2 square centimeters, and the CT assessment. As we said, it is crucial to assess with CT such patients that we plan to proceed with, as we said, the Lux-valve, since there are specific characteristics. For example, we have a minimum diameter of the internal transjugular vein, brachiocephalic vein of 8 millimeters. We have to have RV length more than 45 millimeters. We have to have thickness of the intraventricular septum of at least 6 millimeters and an angle of the tricuspid valve annulus with the septum, the intraventricular, between 80 and 100 degrees. So there are specific and criteria to choose such patients. So we proceeded with the orthotopic independent radial force valve, the Lux-valve, and here we see the valve. Dr. Katsianos commented on the valve before. As Dr. Spargias also said, it stabilizes with two graspers, two rabbit ears, as Dr. Chrysoheris said, and the anchor that we set in the septum.
Kyriakos, just to clarify that the reason this patient was excluded from EVOQUE was the plaster septal leaflet. So the septal leaflet was on the septum, so there will be no space for the hooks, the EVOQUE hooks, to go behind.
And here we see the video of the intervention. We will move on. The preparation of the valve is very thorough from the proctors, and we proceed with ventriculography for road mapping. We see the pigtail.
You see, the preparation is very tedious. There are multiple tiny nitinols that they have to be pinned in specific places for the release.
I'm sorry. Here's the insertion. We pre-dilate, as we said, with 30 until 33 French of the right internal jugular vein.
Κυριάκο, το βίντεο δείξει, γιατί εδώ πήγε στο τέλος.
Πήγε πίσω. Yeah, sorry.
Ας το παίξει.
Now we have introduced the sheath. We stabilize. I'm sorry if I press here. Sorry. And here we see the stabilizer, the sterile stabilizer. Now the delivery system is coming.
As you see, the stabilizer is a different concept than what we know about the stabilizers of the systems that are coming from the leg. A lot of arms, and it can go anywhere, but you need to stabilize the system very well, because even 1 millimeter of movement from outside will have a big effect when you're into the heart. So it has to be absolutely stable on the table and not moving.
So we introduce the delivery system initially in the atrium. It is with a wire, and then we introduce the system in the ventricle, as Dr. Sparga said also before, without a wire, through flexing the system.
So the movements here to get coaxial, the anterior posterior, if you advance you go posterior, if you pull back you come anterior, and then the septal lateral it's by torquing, if you torque you go septal, counterclock you go lateral. And then you can also use, of course, the flex of the system that will also bring you anterior posteriorly. If you flex, you come anteroseptally. If you unflex, you go posteroseptally. So I think the secret for all these capsule valve cases is to be absolutely coaxial. So you see here the septal lateral on the right image, and the anterior posterior on the left image. The septal lateral, it's very good. You agree? It's the trajectory is good. The other one you cannot see in because you have to bring the caliper across, but probably we'll see it later. It appears to be in the center. It may have a posterior trajectory. Now, yes. So now you can see he moves the caliper there. It's quite central, probably with some slight posterior trajectory, which you can correct by flexing the system. So you have two ways to, if you just want to come anterior, you flex the system. But if you want to move all the capsule anterior without changing the angle, you just pull it back.
It looks like the maneuvers that you use in Mitra clip. I mean,
it's similar with the maneuvers you use in tri-clip or Pascal in the tricuspid. So
the anterior and posterior.
Yeah, and the terminology is similar.
Terminologies, yes.
So we begin to unsheath the system. We see on the left picture, the fluoroscopically, the unsheathing of the system, so that the two graspers, as Dr. Chrysoheris said, the rabbit ears come gradually out. We want that these two graspers, the anterior and posterior, are about 1 centimeter under the annulus before we proceed with the exposition of the graspers. Dr. Chrysoheris is looking thoroughly through the valve. We have to be sure that we have that we see leaflet above the graspers, the anterior and the posterior, before we can proceed with the next step. It is unsheathing the ventricular portion of the valve. I'll try to move on. In cases that the TOE imaging is not adequate, it is described that we could use ice. So we see the rabbit ears are orthogonal, perpendicular to the system. Moving on. And we see that now we're satisfied with the leaflet positioning above the rabbit ears, and we have revealed the ventricular part of the valve. We see that the anchor septum, the anchor is towards the septum, the interventricular septum, and we see also the nice movement of the two graspers. Now we have also, we can see the tube in the middle between the graspers that we are going later on to place orthogonal to the membrane of the septum membrane.
Kyriakos,
Yes.
on the right image here, we see that we can advance a little bit the valve to come into to engage the annulus as possible to reduce any PVLs before we do the final stabilization of the valve with the anchor in the septum.
Thank you, Michalis. Since the system is still attached to the delivery system, we can do this fine adjustment, as Dr. Chrysoheris said, so that we are satisfied and we see that there is no PVL before proceeding. So we'll move on a bit. We have released also the atrial part of the valve, and now we see the tube, the anchor, placing orthogonal to the membrane of the anchor, of the septum anchor.
So this valve releases in a very quick succession. Once we know that the hooks are below the anterior and posterior leaflets, and the position is corrected so we don't have any PVLs, the valve opens in a very quick succession, and it's open. You see it open here, and now we have the deployment of the anchor at the septal level here, which is done under fluoroscopy and echo guidance, as you can see here.
These are those nidules. Michalis, can I have this? You see the valve is still connected to our system, although it's released. So the flange is open, the valve is open, the hook through the fabric is on the septum, but you see we're still connected to our delivery system with these multiple nitinol wires. These were the tedious part that these guys were doing in crimping the valve. And now this is the final release of the valve when you release those multiple nitrile hooks, and now the valve is completely free. And then you have to reverse all the manipulation you did earlier. You see how we straighten the capsule to make sure that we're coaxial with a tab that is still in the ventricle, and we pull it back slowly, and the procedure is finished.
Retracting the system.
And here we used, if I remember well, 2 proglides.
That's correct.
So it's not surgical cut down, it's with puncture of the jugular, echo guide, and 2 proglides at the beginning.
Yes, this valve offers another option for patients with large annuli till 70 millimeters, as Dr. Spargas mentioned before. We introduce the system initially with a wire in the atrium, and then we proceed without a wire. We introduce the system in the ventricle. We see that the valve, we assess the delivery system and the positioning of the valve to be coaxial to the valve. We check the anterior, posterior, and septal lateral, and we correct it through maneuvers. We adjust the depth and the trajectory. We use MPR for coaxiality to the annulus plane, and we expose the two rabbit ears at the beginning, then the ventricular part of the valve. When we see there is no PVL, we proceed with exposing the atrial part, and then we anchor the valve with the 3 nitinol anchors. Yeah, this is what we presented, and here we see nicely fluoroscopically the tube, as we said, orthogonal to the membrane of the septum. And here are the hooks, the 3 nitinol hooks, which are fired through just pressing a button, the delivery system.
So this system has 2 passive components of anchoring, which are these rabbit ears, and 1 active component, which is the hook that is pinned into the septum, and also the atrial flange, which is also a passive component for anchoring and stabilization. And in comparison, the Evoque has passive, mainly anchoring with the hooks. There's nothing active. And I don't know, I think the footprint, the metal footprint of this device is probably less than the metal footprint of the Evoque valve. But none of the 2 exerts a lot of radial force on the annulus, because they are not anchored like the aortic valve on the annulus. They have anchoring at other levels and with other manners. And because there's basically the annulus of the tricuspid valve is virtual, it's not a real annulus.
So risk of embolization, if not delivered properly?
If the anchoring is correct, then you shouldn't have it. And the initial part is, we are very familiar with clips in the tricuspid valve. So the initial part is like a clip. You have to make sure that you have the leaflets above. Once you do that and you release the valve, and you're coaxial, it stays there. And then you do the active fixation.
Here we see immediately after the RV function on the table. RV STDI is impaired and TAPS dropped off as well. So even the appearance of the right ventricle seems to be a little bit depressed. So we initiated some Milner-known preemptively, and the patient did well. Was able to get out of the hospital within the next 3-4 days.
Congratulations, really. We watched 3 important tricuspid valve replacement cases, and I really want to congratulate the whole team, Professor Spargias and his team. So, do you want to add some comments? Okay.
What was the mean gradient? Gradient of the diastolic gradient of the valve was low. It was 1.
I think these cases are not only the first cases in Greece, and these are the first cases in Europe. So, congratulations to all team, and I hope these all procedures will light the literature and will be very beneficial to all patients. Thank you.
Thank you.